So once again, good morning, everyone. Thank you for joining us. My name is Brooke Oliveri. I'm the manager of the Long Island Health Collaborative. For those of you who may not know, the collaborative is a group of 300 plus local hospitals, county health departments, community-based organizations, all working toward improving the health of Long Islanders. So some housekeeping before we get started today. Today's program is being recorded. It will be available on our YouTube channel after the presentation. We will have a robust Q&A session at the end, so please save your questions for the end of the program. And I do want to thank AARP, our sponsor. We are very excited to have them on board with this series. And now I would like to introduce Paula Baker, an AARP volunteer, to say a few words.
Thank you, Brooke. So my name is Paula Baker, and I am an AARP volunteer with the Huntington team. On behalf of AARP, we welcome you to today's Healthy Talk with a Doc webinar. We are committed to helping you stay healthy and stay connected. So we congratulate you for taking the time to learn more with AARP and the Long Island Health Collaborative. AARP, as you may know, is a nonprofit, nonpartisan membership organization for people age 50 and older. There are 38 million members nationally and approximately 2.5 million in New York State, and about 500,000 living on Long Island. AARP works to strengthen age-friendly communities and make for happier, healthier residents of all ages. And we advocate for what matters most to people 50 and over and their families, with a focus on health, security, financial stability, and personal fulfillment. To learn more about other online classes, events, local discounts, volunteer opportunities, and more, you can go to aarp.org/near-you. Thanks, Brooke.
Great, thank you so much, Paula. Now, before I introduce you to our featured speaker today, we do just have a few questions for you to answer. I'm going to go ahead and launch those right now. If you wouldn't mind, please giving us your feedback. We would very much appreciate it. We have about 6 questions here. It shouldn't take too long. And your feedback really helps us to inform future programming and to assess the success of these programs. So we really appreciate it. I'll just give it another minute here, just to give everyone some time. I see a lot of answers coming in. Thank you all for providing your feedback. We really do appreciate it. Okay, I have 60%, so I'm just going to give it 30 more seconds. If you haven't answered, please go ahead and do so, and then we'll move on. All right, a lot of great answers here. I am going to close the poll. Thank you so much for all of your feedback. And without further ado, I would like to introduce our featured speaker today, Dr. Stelios Koutsoumbelis. I hope I got that correct. He is the Chief of Orthopedic Surgery at Mount Sinai South Nassau Hospital. He is an orthopedic spinal surgeon who specializes in the management of all spinal and scoliosis disorders. And we are very excited to have him for today's program. So welcome, Dr. Koutsoumbelis.
Thank you, Brooke. Thanks, Dana, for setting us up. Paula, thank you for the introduction to AARP, or ARP, as most of the patients say they have when they come in. Today is really focused around a nice Q&A interactive session. We're going to be speaking a bit to both osteoporosis and to arthritis. The conditions today are mostly in the age group of some of the callers that I've been told, typically knee and hip pathology. We'll be talking about some lower back pathology. As Brooke said, I'm Dr. Koutsoumbelis, or Dr. K, as a lot of people around the hospital call me. I'm chief of the orthopedic service here on Long Island for Mount Sinai. I'm also an orthopedic spinal surgeon, and that's all I perform is spinal surgery, but we will be talking about the other things. You can ask me any orthopedic questions you have. We have now moved Mount Sinai South Nassau into a center of excellence. Over 1,000 cases per month are being performed there, more than almost anyone in the tri-state area. Our joint replacement surgeon has become a center of excellence from the Joint Committee, and our complex spine has become a center of excellence as well. And that's really, to no degree of my own, it's really been people like Brooke and Dana that have allowed us to create that by putting together talks with folk like you to really make South Nassau into what it's been. So thank you to everybody here for being on the call today to make this all possible for us. Brooke has put together some slides for us, which we will go through. So some of the things that we're going to go through today: arthritis, osteoporosis, how to keep yourself moving, what are some of the preventative tips. As a surgeon, we're looking on the treatment side of it. So we're looking at how do we manage you conservatively in the office, and then perhaps a bit more in the operating room surgically to get you back to moving. But obviously, that's always the last option for people. We try to teach the patients ways that they can prevent this, so they can move forward. Next slide.
Dr. K, there's only this one slide, so feel free to go
beyond
okay. These bullet points.
Oh, sure. No worries.
Thank
Yeah.
you.
Okay. Yeah, no worries. So I'll move back. So, Brooke, can you see me? Okay.
Yes, I can hear and see you.
Very good. So again, when we look at arthritis and pathologies of both hip and knee, oftentimes what will happen is people have a genetic predisposition to having issues with arthritis, whether it be the knees, the hips, the low back, but oftentimes it is somewhat comorbidity induced, meaning that patients that are a little heavy set, or in some cases a lot heavy set, those are typically the patients that have problems with arthritis that begin first. So a way to prevent that is to try to keep yourself in good shape, to keep the weight down, to keep things in control. And that comes into conjunctions with lifestyle habits. So eating and drinking has to be appropriate, getting nutrition involved, talking to your primary care doc about your diabetes and are you smoking, and all of these things that really make exercise possible or not possible. And that's what leads to the best type of preventative. If everybody could just mute themselves if they're not speaking, otherwise you get a feedback on the Zoom calls. In regards to keeping yourself moving, it goes in the same hand, right? So oftentimes, again, I don't mean to beat up smokers and diabetics, but those are always the two categories of patients where things don't work out so well. Because what happens with a smoker is that in addition to demineralizing the bone and to degrading the cartilage in the knees and the hips and the back, then they develop things like lung issues, asthma, COPD. It prevents you from being able to walk. So it's sort of this cycle that needs to be broken from an exercise standpoint. The problem with diabetes is there are some people that are diabetics, especially type 1 diabetics, that they're born that way, they can't control it. But most diabetes comes from obesity and being overweight. And that goes hand in hand with poor nutrition. And then that leads to a lack of mobility from a lack of exercise. And it's funny because the diabetics that I see in my office that we take to surgery that are well controlled, whether they're either be type 1, they were born that way, or type 2, and they're actually in great shape. They work out almost every day. They eat very healthy because they know they're already starting out with a lesser deck or a lesser hand than the other people. So they need to sort of get their game up to keep going with that. And then as far as osteoporosis, again, as you age, especially ladies that age after they're postmenopausal, the estrogen receptors stop being as efficient as they were 20 or 30 years ago. And then the bone demineralizes quite quickly. In that standpoint, oftentimes we start with a regimen of vitamin D and calcium, and then move forward to some of the pharmacologic agents, whether they be either oral form or injectable form, depending on what the DEXA scan or your bone density scan shows. In general, orthopedic surgeons such as myself, we don't manage that pharmacologic agent. At the hospital, Mount Sinai South Nassau, what we have set up under my supervision has been what's called the Own the Bone. It was a program that we set up to specifically look at bone demineralization, osteoporosis in patients that come in with hip fractures. We are probably within the number 3 center for hip fractures in the New York metro area. And for that reason, this was a very important venture for us to work on. And through our works at Mount Sinai South Nassau, we have expanded this Own the Bone program, which deals directly with osteoporosis throughout the entire tri-state area through the Mount Sinai health system. What that allows us to do is provide a registry for patients that have hip fractures. But for everybody on this call, hopefully most of you have not had a hip fracture and don't want to ever have one. And part of that preventative is, again, aside from talking with your primary care docs, as you get a bit older, maybe you use a cane or a walker or some assistive device to do things. And again, it's life decisions. You don't get up on the chair to change the light bulb. You have somebody else do that. But just from a day-to-day basis, keeping your osteoporosis in check by way of being a part of a registry like this, being a part of the Mount Sinai physicians group, where you'll see a rheumatologist, you'll see an obstetrician who's specialized in bone matrix. They will get you your bone density scan. They will put you on the appropriate agents, whether it just be vitamin D and calcium, which you buy from CVS or Rite Aid, or something a little bit more complex than that. Maybe you have to go for a monthly injection, but it prevents you from needing major surgery like a hip fracture at some point in your life and dealing with all of the comorbidities that come along with that. Why don't we open it up to some questions? I think the talk will go on. I've seen some questions pop across the bottom of the screen. Brooke, I'll let you call on people to do so. And then anyone, if they just want to, there's an option to raise your hand on Zoom calls. You can do that, and then we'll call on you to answer a question.
Exactly. Yep. Please feel free to do so, or unmute yourself, or put your question in the chat and we'll get that answered for you. I do see a question that requires some clarification. What are the age and weight requirements for knee? I'm not sure what the full question was. So Claire, if you'd like to clarify, please feel free to do so.
Yes, hello. Yes, my doctor just told me what you're asking is that I could be going toward an operation. I've had my right knee done. This is my left knee now, but to have it replaced, yes. And I didn't walk very much during COVID. I made mistakes. I should have done more. But now I was told I should go to physical therapy and take a medicine called Meloxicam. It's 15 milligrams, and that's a pretty powerful pill, I understand. So I'm just trying to not feel too much pain. I use ice on my knee. But yeah, that's where I am, and I'm overweight, as you said, and again, not exercising enough.
I see. Yeah, in general, the forum like this is not for medical, even though I am a doc, it's not for medical advice to tell you what to do or not to do. In general, it sounds like you're doing everything you should be. I would have you probably see one of our knee replacement specialists to talk to the points that you made. Remember, every patient is it's not a cookie cutter, even though the operations we do are very cookie cutter like, and that's what you want. That's how you get good outcomes. The knee replacement, we joke sometimes with the knee replacement surgeons, we say, I know how to do 4 operations: left knee, left hip, right hip. But the truth is, you want a surgeon that operates like a robot, but in the office during the consultation, the patient gets a very specific and tailored treatment plan before they go to the OR. So again, that's something you're only going to find at Mount Sinai South Nassau. And I would tell you to call to make an appointment with one of our specialists who can walk you through all that. But in general, it sounds like what you're doing is the right thing thus far.
Thank you very much. I appreciate
You're
that.
very welcome, dear.
Thank you.
Thank you so much. Barbara asks, what is your opinion on extended use of ibuprofen for arthritis pain?
Again, so without giving too much medical advice here, in general, NSAID therapy for a patient that's over 65, that's continuous NSAID therapy from the literature would suggest to not continue past 4 weeks of use without a holiday for at least 50% of the time. So if you're on some sort of prescription strength NSAID protocol, whether it be meloxicam like the last lady had spoken to, or ibuprofen 600, which is the 3 times a day, which is the typical prescribed medicine, you shouldn't be on that for more than about a month, and then take a 2-week holiday, assuming that your primary care doc thinks that your liver and kidney functions are okay. So again, everything we're saying here, it goes with the devil's in the details. So you can't use this as a dogma to treat yourself. A lot of times, the teams are collaborative. So your primary care physician is really the one you've built a very nice relationship with. They manage a lot of this. They manage the NSAID therapy. Us as specialists, me being a spinal specialist, others being knee and hip, when you meet with them, that's the time to discuss how long should I be on anti-inflammatories? When is physical therapy not going to work? What do the x-rays look like? When am I a candidate for gel shots in the knees or cortisone shots in the knees or hips? And then when am I a candidate for replacement?
Great answer. Thank you. Another question in the chat. Are there any dietary recommendations for arthritis that you would make?
In general, diet and arthritis is not well linked. There is a big push from a lot of supplement companies and media to maybe have you believe that way. But in general, arthritis is more of a genetic disposition, and it can be an autoimmune condition as well, or it could be a combination of them along with being overweight, diabetes, and or smoking.
Okay.
But in general, eating healthy is good for a lot of reasons. Leave it at that.
Great advice as well. Does osteoarthritis always get worse with time? Mariana asks.
So again, for those of you joining the call, I'm Dr. Koutsoumbelis from Mount Sinai, South Nassau. I am a orthopedic spinal surgeon. So I will answer that from a spinal surgeon perspective. If you look at lumbar spinal stenosis, which is contributed from arthritis of the low back, the literature would tend to tell us, and my practice would tend to tell us, that about 70% of the patients, they don't get worse over time. They tend to stay where they are and kind of maybe go up and down a little bit of degree of variation, but they stay within a standard deviation. The other 20 to 30%, a small subset has an acute drop where they get worse very quickly. And the other, let's say 80% of that 20 or 30, so about 20% of overall patients, they tend to get worse very, very slightly over a very long period of time.
Interesting. We have quite a few questions in the chat. For osteoporosis, is swimming as helpful as weight-bearing exercises?
No, it's actually worse. Weight-bearing exercise is better for bone mineralization. So swimming you may like doing because it's easier to do and it's better on the joints. But for bone mineralization, you're better off with weight-bearing exercise. This is why astronauts have osteoporotic problems, even though they're not, astronauts are 30, 40 years old. They come back to Earth with a decreased bone density.
Very interesting. Another question. How long do gel injections work for?
Well, my crystal ball is broken today.
Darn it.
But in general, there's a progression. Usually gel shots would be like a second line treatment. The gel shots we use in the office can be either 3 doses or 5 doses. A lot of it depends on, I hate to say this, but it's what Medicare will cover. Medicare, as you know, is the bane of a lot of our existences, and it limits your access. But in general, the gel shots, if you get relief, they could last 3 to 6 months. Sometimes they don't work at all. The patients are their own person in their own right, and you can't treat two patients the same exact way.
Right. All right. Jane asks, it seems counterintuitive, but is walking good if you have osteoarthritis in the knee and the hip?
It depends what you can do. So walking is always good for a lot of reasons that we've touched upon already. Obviously, if you walk too much and you have a lot of pain, then you shouldn't do that because there's no reason to writhe in pain. But there's no contraindication to having arthritis and walking.
Okay, great. What other exercise do you recommend for those with joint issues?
I recommend going to physical therapy.
Good
This is
answer.
the thing. It's not so much exercises. It's very difficult to show it. It's very difficult to show patients how they should or how they shouldn't exercise. And to give somebody a pamphlet or to say, oh, you should do this or that, and Google it, it's very difficult. It was an old saying that a former attending of mine told me when I was a medical student, almost 20 years ago. And he said to me, Stelios, what is the foundation of civilization, right? And it's the division of labor. So there's a reason that all of us specify to do different things, right? So like I only do spinal surgery. Physical therapists only do physical therapy. Primary care doctors, they know a little bit about a lot of stuff, but not a lot about any one particular thing. And the reason to do that is that's how you get good outcomes. So at Mount Sinai, South Nassau, when you become a patient and a part of the team, you get a team approach. You get an orthopedic surgeon to manage parts of the orthopedics. You get a primary care doc, you get physical therapy, you get rehab, you get your imaging studies, and that collaborative care is what leads to a good outcome.
So true. Let's see, what other questions do we have here? Is there an age that knee replacement operations should be avoided?
In general, it has more to do with your comorbidities. Again, I would tell you to speak to your knee replacement surgeon about that.
Right.
But there has been patients even in their late 80s that have had knee replacements. So it's not an age; it's more of a lifestyle and what the overall general medical condition is like.
Makes a lot of sense. Joanne asks, what is the difference between gel shots and cortisone shots?
They're for different things. Typically, cortisone shots are for more acute pain. So when a patient comes in and says, I have this acute flare, my knee is killing me, or my hip is killing me, or my shoulder, a cortisone shot will be to bring down some of that initial inflammation. Gel shots typically, like I said before, are second line treatment. So patient may have had cortisone injections, now has more of a dull ache and is looking to buy themselves some time until they need a knee replacement. Usually we see gel and shots are usually common in the knee. And that would be the time to do those.
Okay. I think that about wraps it up for the questions in the chat. I know you answered quite a few of them during your presentation, so thank you so much. If anyone has any final questions, please feel free to put them in the chat. Otherwise, thank you so much, Dr. K. It was great to have you here today.
Thank you, Brooke. Again, everybody on the call, I'm Dr. Koutsoumbelis from Mount Sinai, South Nassau, and the Orthopedic Center of Excellence that we have. Brooke and Dana can give you the appropriate contact info to get in touch with any of our specialists, whether they be orthopedic surgeons, rheumatologists, primary care, or any of the other ancillary services like we spoke.
Yes, and I do see questions in the chat regarding referrals, so we will definitely follow up with that information for those of you who are asking.
Perfect, thank you.
All right, thank you so much to everyone in attendance. Thank you to AARP, to Dr. K, to Dana, and I hope everyone has a wonderful day.
Same to you. Take care.
Actually, before we go, I do have some final slides for everyone. As Dr. K mentioned, walking is a great form of exercise. We do just want to remind you about these tips and laws for walking safely. Always use the sidewalk. If there is no sidewalk, walk facing traffic. See and be seen, wear brightly colored clothing. Cross streets at corners or in crosswalks. Don't text or talk on your cell phone while you're walking. It can be just as dangerous as, using your cell phone while you're driving. And for more information, you can visit walksafeli.org for more tips and laws like this. And for those of you still here, we do just have some final poll questions for you to answer. I'm just going to launch those here now if you have a moment.
Could I just ask one question, please?
If Dr. K has time, certainly. I'm not sure if he's still here.
Yeah, I wanted to ask, is there an internet station that would provide grades of doctors that perform knee replacements and where they're rated so that we can pick, in a referral, someone with high grades?
That is a great question. I know there are many, third-party grading and rating systems for physicians. I really don't have a recommendation there. Maybe start with your primary care physician and go from there.
Thank you very much.
You're welcome. Sorry, I don't have a better answer for you there. And thank you to everyone who's answering the polls. We so appreciate that. Dorothy asks in the chat, how can we access this presentation again? It will be on the Long Island Health Collaborative YouTube channel, which if you go to lihealthcollab.org, you'll be able to find all of our YouTube presentations linked from the Talk with a Doc series. And I still see some answers coming in, so I'm just going to leave the polls up for another minute or so. And once again, thank you to everyone in attendance. We so appreciate your feedback here. Thank you from Georgia. Wow, thank you for joining us. While you're answering those questions, I will just mention we have one more Talk with a Doc coming up on Wednesday, July 13th, and all about asthma, bronchitis, and COPD. And the Walk with a Doc, we have two events that will culminate at the end of this series, one at Belmont Lake State Park on Saturday, August 6th, and one at Jones Beach on Saturday, August 13th. So we hope to see you there. And once again, thank you for all of your feedback. I still see some polls coming in, so I will leave it up.
And thank you, Brooke, for such a wonderful program.
Oh, well, thank you. I'm so glad you you enjoyed it.
Very much.
Yes, I will put the link to the YouTube channel in the chat here as well. Yes, a great note. Parking at the walking events is free. The events are completely free. All you need to show up with is yourself and your sneakers. So we would love to see you there. All right, we've got some great participation in the polls. I think I'll close it out. Once again, thank you everyone for your participation, and we hope to see you at the next one.
Thank you.
Thank you. Have a wonderful day.
Thank you. You too.
Thank you.